Okay, thank you so much. So I'm going to take us through this session. We have said it takes two to tango, and for STIs, it actually takes two to tango. It's going to take two to help us prevent, to help us treat, as I'm going to take us through this presentation. I do not have any conflict of interest to declare. This is the outline of my presentation. A little look at the background, then we'll finish with the key takeaway messages. So, over the past 24 years, there has been an upward trend of the estimated new cases of global sexually transmitted infections globally, with more than 1 million curable sexually transmitted infections acquired every day worldwide. Of note is that these high estimates have been there pre and post introduction of HIV pre-exposure prophylaxis. So it's something that has been there, and when we have had now HIV pre-exposure prophylaxis, we have been able to unmask the hidden STI that we have not been paying attention to. What are some of the STI prevention approaches? So we have different ways in which we can prevent sexually transmitted infections. We have primary prevention approaches and secondary prevention approaches. For the primary prevention approaches, one of them is sexual health promotion. We've just heard from our previous presenters that information is power. And so once we give ourselves that information about STI, that is the beginning point of us preventing the STI. Because once you know what you're going to encounter, you're going to be in a position to know how to prevent yourself from getting that sexually transmitted infection. On secondary prevention, we have asymptomatic infections that can only be identified through testing. And that's where my colleague will come in and see what you can do to detect those, because that's also one way of preventing. Because once you've been tested and you know what you have, then you're going to get treatment and you're going to know how to prevent yourself. Then we also have, for the symptomatic infections that are identified through clinically indicated routine testing that we are going to talk about. And so my aim today was to talk about three different new strategies of preventing sexually transmitted infection, both bacterial and also viral. My first presentation here talks about expedited partner treatment. And here, this is a clinical practice where you treat the sex partner of a person who has been diagnosed with a sexually transmitted infection. And mostly we do this for chlamydia, trachomatis, and Neisseria gonorrhea. So you provide medication to the person who has been diagnosed with a sexually transmitted infection to take to their partner to take that medication. And the doctor or the clinician does not necessarily have to examine the partner of that particular patient. And this intervention works very well when we have diagnostics, which is one thing that we are lacking in low and middle income country. Because when you have diagnostics, you're going to be able to know that this person has this infection, and so I'm treating this, and so their partner can also take the same medication to treat themselves. If you do not treat the partner, there is high chances that you will treat the person that you are having in front of you. After some time, they'll come back with the same infection. Why? Because there has been a reinfection from the partner that was not treated. So expedited partner treatment is effective, is routinely used in some parts of the high-income country, particularly the US, and has been recommended by the Center for Disease Control, particularly for male partners of women who have been diagnosed with chlamydia infection or gonorrhea. And like I had said before, diagnostics are required so that we're able to identify what we are treating and what medication we are going to give to the partner. Studies have been done in Africa to look at acceptability and effectiveness of expedited partner treatment. And we have found high acceptability and uptake of expedited partner treatment by both the index partner that we have tested and we are treating, and also their partners. And through this, there has been reduction in the incident infection. So for those who are followed up, there were fewer infections compared to those who had not taken up expedited partner treatment. Though these studies done in Africa had a small sample size, and therefore probably providing opportunity for larger studies to be done to show the true effectiveness. Of note is that there are still notable barriers, and these barriers come from, I think one of them is what one of our audience asked a question about why we are leaving out the adolescents and young men, because for you to take the medication, these studies were done among young women, and we find that sometimes they are afraid to take this medication to their partner because they are going to be asked questions. But if we had also empowered the young man or their partner, their male partners, to know about STIs, to know about how STIs are treated and that they can be treated through expedited partner treatment, it means that when this young woman brings that medication to me as their partner, I'm going to be knowledgeable and I'm going to know why I'm going to take that medication. And that is going to reduce some of the barriers that have been noted before. Next, I'm going to talk about doxycycline post-exposure prophylaxis for the prevention of sexually transmitted infection. And doxycycline is an antibiotic. It is safe, it is well tolerated, it is affordable to most people. It has been used safely before and effectively for prophylaxis, for example, against malaria. For the people who have acne, we have used doxycycline for that. One thing to note that is that it is not routinely used for the treatment of sexually transmitted infection, and there has been no tetracycline resistance against chlamydia trachomatis or Treponema pallidum, which causes syphilis, that have been seen when using this doxycycline. And so, doxycycline was tested to see whether it can prevent sexually transmitted infection when taken within 72 hours of unprotected sex. So in this case, individuals were given 2 tablets of doxycycline, that is 100 milligrams each or 200 milligrams, taken within 72 hours of a condomless sex. That is similar to what we do with emergency contraception. You have unprotected sex and you are not sure of your dates. You take emergency contraception within 72 hours to prevent yourself from getting unwanted or unplanned pregnancy. That is the same mechanism we are using here. So, doxycycline post-exposure prophylaxis was found to be effective in reducing incident sexually transmitted infection among cisgender men and transgender women who had a high burden of sexually transmitted infections. And these 2 trials were done, one in France and another one in United States of America. But we also conducted the first trial of doxycycline post-exposure prophylaxis among cisgender women here in Kenya, in Kisumu, Kenya. It was an open-label trial that enrolled 449 women between 18 to 30 years of age who at that time were using HIV pre-exposure prophylaxis. And in this study, unfortunately, we found that among these women, doxycycline post-exposure prophylaxis did not reduce incident sexually transmitted infections. And one of the things that came up was because of adherence. Again, I think because of, if you can involve everyone through gender transformative approaches, where we involve all the partners so that everyone knows what is going to come, then we are not going to have issues with adherence and now effectiveness. Lastly, I'm going to talk about human papillomavirus. Human papillomavirus is a common viral infection to which almost more than 90% of cervical cancers can be attributed to, and the burden is mostly felt in low and middle income countries, including our country here in Kenya. We have vaccines against human papillomavirus, and currently the vaccines are prophylactic and intended to be administered prior to exposure to human papillomavirus. The vaccines were first introduced in 2006, and initially we were giving 3 doses. And then in 2014, the WHO reduced the dosing schedule to 2 doses in pre-adolescent and in adolescent girls. But recently, we've had this study on single-dose human papillomavirus vaccine, which was shown to be 98% effective in providing protection against human papilloma virus. So ultimately, a single-dose regimen will likely increase the vaccine uptake and decrease the rates of cervical cancer and cervical cancer-related deaths in high-burden, low-income countries. So this is the vaccination schedule. So with that results of the single-dose human papillomavirus vaccine study, now we have the option of either taking the single dose or taking the 2 doses, depending on the country and depending on the availability. And this vaccine is available to adolescents. We tend to target those who are between 9 to 14 years because probably they have not had their sexual debut, so they have not been exposed to the human papillomavirus infection. But still, even if you are above that age group, you still qualify to be given human papillomavirus vaccine. And I want to encourage all of us here to take the vaccine. If you have daughters, let's take them to get that human papillomavirus vaccine. So what are the key takeaway messages from my presentation? Number 1, there's a rising incidence of a global sexually transmitted infection. And this is a challenge because of the risk of acquiring HIV when you have these STIs, and also the morbidity that comes with the STIs, particularly in women, the chronic pelvic pain, chronic low abdominal pain, that is infertility, and even when you become pregnant, when you have an STI, it has a lot of morbidities. Second, there is need to advocate for partner involvement in the treatment and prevention of STIs. And we have things like the expedited partner treatment. Someone is going to talk about partner notification services. Thirdly, doxycycline post-exposure prophylaxis is effective in reducing sexually transmitted infection among cisgender men who have sex with men and transgender women. And therefore, it's something that we should start considering for prevention of STIs. And studies are ongoing among cisgender women to find out its effectiveness, despite the results that were found in the first and the only trial that was done here in Kenya. So evidence shows comparable efficacy and effectiveness between the single-dose and multi-dose schedules for human papillomavirus vaccine in preventing human papillomavirus infection. And that prevention lasts up to 10 years following vaccination. And so this is something that we should also encourage everyone, all our daughters, and also our boys to take up the vaccine whenever the program allows. I'd like to acknowledge the workshop organizers and my colleagues who helped me in preparing this presentation. Thank you so much.